invite Dr. Shobhit Chawla for his keynote talk on the emerging role of OCTA and the ultra-wide field imaging in retinal diagnosis and management. Sir.
Thank you very much, Anirudh. So a good imaging system is what helps me see more, make a diagnosis, follow up my patients, make a treatment strategy, and monitor that medical or surgical treatment. And that is what ultra-wide field imaging and OCTA have provided. So when we compare the various views, we have the slit lamp view, the direct ophthalmoscope view, the indirect ophthalmoscope, the traditional fundus view, and the Claris wide field, and the ultra-wide field imaging views, which are commonly used, and also the Optos. So there has been good evolution of fundus imaging right from 1926, when the first modern fundus camera was there, to 1992 when ICG came, and now finally in 2018 when ultra-wide field true color imaging emerged, while we still had imaging from Optos earlier and by the Heidelberg system earlier. So these are some of the options with us, and which give us various fields of views, ranging from 200 to 105 in the wide field, 133 Strangui lens going up till 150 in the red cam. Now, it was very relevant in the last 2 years, even for simple patient screening in the outpatient, when we were too afraid to come in close proximity to patients. We could just screen using a nice wide field color image and then do indirect ophthalmoscopy or more imaging as needed. So these, in diabetic eyes, we could avoid angiography and just do an NFAS surface OCTA and get an idea of the perfusion. Small pupil, a patient hypertensive for 5 years, poor dilator. In screening, we see, and the pupil was very small to allow good indirect. We see a hemi-retinal vein occlusion on the first visit and then got treated with laser photocoagulation after a wide field fluorescein angiography. Another image of idiopathic vasculitis, lasered before, came for follow-up, and there was, we could see on imaging some red dots superiorly, and did an angiography, and there was an NV sitting in the other quadrant. So this is all the relevance of wide field imaging. And when you go in depth and combine it with a wide OCTA, you see these new blood vessels. And these suspicious areas, you can again do a montage, and you can do various cuts like the NFAS image, the surface image, and the NFAS VR interface, where you see these vessels are visible and are little elevated from the retinal surface, as you see on the image in the right. So all the information you are getting without doing a dye injection. Then you take a cut through that and you see the NV new blood vessels sitting at the vitreoretinal and a localized vitreous small detachment going on the posterior hyaloid with the potential to bleed and cause sight-threatening complications. Another montage with all the imaging of the same case, where you have the fluorescein, so you combine all the modalities and get a better understanding of the disease and then do your treatment. In diabetic retinopathy, it's a great tool to monitor progression, and many patients have predominantly peripheral diabetic retinopathy it's very important for pre-surgical planning and plane of dissection, as I'll show you. So this is a very relevant study utilizing two types of fundus cameras, one the Optos and one the Clarus. And in Asian and Indian eyes, most of the lesions were found in zone C1, which is the posterior probe, 38.5 in the zone C2, which is the mid-peripheral zone, and peripheral lesions were relatively less. So primarily South Asian population tends to present with primarily center-involving lesions more in diabetic retinopathy. This was the study in investigative ophthalmology and visual science in 2018. And similar results were seen in an Indian study, very well done, and it monitored all these lesions and found that sight-threatening lesions such as NVE and NVD were detected equally by both Optos and Clarus in C1, whereas other lesions like cotton wool spots, hard exudates, and subhyaloid were identified better by the Zeiss Clarus in zone C1. So maybe pertaining to our context, the central imaging has more value than peripheral imaging alone. So you have a patient who you are following up after panretinal photocoagulation. You see some areas of missed panretinal photocoagulation, and you can do an imaging and fill up that area. A case of proliferative retinopathy with tractional RD, excellent image for planning your treatment, and I would go in for bimanual dissection in such a case. Another case showing neovascularization in the periphery also, along with the central tractional RD with a membrane. In retinal degenerations, you are seeing the fundus, but when you do a pan image, you see the periphery also, and you see the lesions all over. Good for monitoring lattice degenerations and deciding whether you need to coagulate or not, depending upon the presence of hole and the state of the vitreous. In rhegmatogenous RD, we routinely image now to see and decide whether we would like to go ahead with a buccal or a vitrectomy in a particular case, and make our decision according to the configuration, size, and location of the breaks. Another patient with a meiotic pupil came to the OPD, and we were screening him, and we saw this subclinical RD. He underwent a photocoagulation. He was a 68-year-old physician and was complaining of flashes and floaters, and the pupil was pretty small. A buccal surgery which showed fluid in an 8-year-old boy, and we saw this break which was posterior to the buccal, and the cause of the failure very easily detected by wide field imaging. And you can toggle the magnification to the area of interest where you suspect and see this, and then take the action whether you want to shift the buccal posteriorly or you want to go ahead and do a vitrectomy and laser. In vascular occlusion like central retinal veil occlusion, a fresh case, you see the extent of the disease, and it's almost bordering on to hemorrhagic. You would like to follow up this patient closely and monitor for peripheral ischemia with a follow-up angiography. In an old, dried out CRVO, you see this area with peripheral neovascularizations, collateral at the disc. You take a wide field image and then toggle onto the areas of interest with magnification, and you see so much information. Another case of retinal vascular occlusion. Vasculitis, another patient showing NVE in one area along with hemorrhage, and you can accordingly treat that area. The other eye also shows evidences of vasculitis. Vasculitis with serpiginous and high suspicion of Cox in this patient. Patient had vitritis also to some extent. and we subjected him to other investigations like HRCT for the chest, Manto, and quantiferon gold, which all have come positive, and he's already on ATT. Choroiditis to monitor and see the lesions where areas are active in the periphery. And another case of proliferative retinopathy to see by a wide field OCT scan whether there is traction at the macula to take definitive action or not, or follow up the patient. Here the macula is threatened, so I feel surgery, this patient would be a candidate once the vision starts slipping. Now this is again in a small pupil discovered this peripheral hemorrhagic PCV lesion type lesion in a elderly lady, and you do an ICG wide field and you see those polyps there. This patient definitely requires treatment. Her other eye, again with polyps sitting in the periphery but no leak, this can be watched. So these are the advantages. Central peripheral PCV along with peripheral lesions, again polyps, and this patient also requires treatment, as you can see. A patient who has undergone, only-eyed patient who's undergone more than 30 injections, has been on aflibercept monotherapy, maintains six vision in his only eye, a practicing lawyer, and you see the branching vascular networks. You first do a whole image. Those are some areas which I have lasered also with polyps based on ICG, and when you look at the central magnified image, you see the branching vascular networks which have matured, and such networks have lesser chances of bleed. So imaging combines so much information, so much follow-up care, and so much treatment. You see the same patient showing similar lesions, and you can see on a wide field octa image the branching vascular networks almost looking like a bush, but the vessels are mature, and these patients tend not to bleed later once the branching vascular network matures. A patient with a bullous RD almost touching the lens with PVR underwent, I did surgery for him, and my fellows noticed next day there were some bubbles underneath the retina, and we did a wide field image and then saw this area of interest, and a corresponding OCT shows PFCL under oil. Recurrent submacular hemorrhage, follow-up image with TPA and anti-VGF, subsequently octa can be done to evaluate further management, and a wide field ICG. Thank you very much for your kind attention.